Hi, we are Amy and Abby, and today we are going to be talking about intimate partner violence.
Now, I'm going to discuss our project goals. Our first goal is to develop a comprehensive understanding of existing intimate partner violence programs and publicly available resources with the aim of identifying strategies to enhance their accessibility, utilization, and overall effectiveness. This includes identifying patterns of success as well as areas for improvement across current IPV interventions. Additionally, we want to systematically examine populations at elevated risk for IPV to inform the development of culturally responsive and contextually appropriate interventions designed to address and mitigate IPV within diverse communities.
So, like I stated before, we are going to be talking about intimate partner violence, which is any abuse that occurs in a romantic relationship. So, this can be physical violence, sexual violence, stalking, and psychological aggression. IPV is extremely harmful and can result in injuries and death for some, with 1 in 5 homicide victims being killed by an intimate partner. There are also many negative health outcomes that are associated with IPV, including conditions affecting the heart, muscles, bones, and the body systems. IPV can be prevented, luckily, by promoting healthy, respectful, and nonviolent relationships and communities. Purple, like we have here, is the nationally recognized color for IPV because it symbolizes peace, courage, survival, honor, and dedication to ending violence. IPV affects 1 in 3 women and 1 in 6 men, so clearly this is a very significant health issue. For 1 in 5 women, they experience sexual violence, 1 in 4 experience physical violence, and 1 in 8 were stalked. For men, 1 in 23 experience contact sexual violence, 1 in 7 experience physical violence, and 1 in 24 were stalked. So this is not just an issue facing women, men also face this issue. Another reason that IPV is very significant is due to its cost to society. So, the lifetime economic cost of IPV related medical care, lost productivity from paid work, and criminal justice costs is $3.6 trillion. And the cost of IPV over a victim's lifetime for women was $103,767, and for men was $23,414. So for this project, we did a literature matrix, and in order to do this, we used Google Scholar to find all of the studies that we had used. Keywords such as intimate partner violence, abuse, assault, sexual assault, physical abuse, and so much more helped us find these articles. We reviewed over 50 literature articles in order to find the most effective articles for this literature matrix, and that doesn't even include all the ones that didn't count because of the years that it was in. There were many significant findings, including the fact that minority and immigrant groups experience higher rates of IPV with less culturally tailored services. Empowerment based and culturally adapted interventions are known to outperform cognitive based therapy and Duluth programs when creating these interventions. Training can also boost clinician confidence, which can make them more effective when they're delivering the intervention, so that's something that we really need to do moving forward. Many of the studies lacked rigorous design and structural factors such as legal protections, economic empowerment, criminal justice policies. These are all needed to create interventions that will be effective for the survivors. These interventions will help to deliver the greatest engagement and psychosocial gains. Interventions that have referral pathways, follow up, and multi level policy support are essential for safety that is long term. And that's what we found when we looked through all of the articles. So, AI tools can range from machine learning for risk protection to image analysis for forensic evaluation to chatbot support. There's so many different types of AI tools when it comes to IPV. Natural language processing helps with detecting IPV from clinical and social media data. Predictive modeling shows discriminative performances, whereas natural language processing detected IPV with notable sensitivity. Chatbots were feasible and accepted by users, but they don't have a lot of evidence having a direct impact on reducing IPV, even if it made survivors feel better. Issues such as algorithmic bias, data privacy risks, and barriers to implementation were some of the challenges identified with these AI tools. There's the AI tools such as the one created by the National Institute of Health, which help clinicians by predicting if patients are at risk of IPV by using data collected during medical visits. Current screening tools capture only a fraction of cases, whereas clinical and imaging records provide valuable information in detecting risk. The point of this tool is not to force the patient to disclose their trauma, but instead to help clinicians communicate in a supportive way, while also connecting them with resources and support.
Now I'm going to talk about the public health implications. The findings of this project carry significant public health implications, which highlight intimate partner violence as a pervasive and preventable health issue that requires coordinated, multi-level intervention. Given the high prevalence of IPV and its association with severe physical, psychological, and fatal outcomes, there is a critical need to prioritize IPV as a major public health concern rather than solely a criminal justice issue. Furthermore, evidence highlights the importance of implementing culturally responsive, empowerment-based interventions as a standard of care in IPV prevention and response efforts. The disproportionate burden of IPV among minority and immigrant populations, coupled with limited access to culturally tailored services, points to persistent health inequities. Public health systems must therefore invest in the development and dissemination of interventions that are linguistically appropriate, culturally relevant, and accessible across diverse communities to improve engagement and outcomes. IPV has profound and far reaching consequences for health and well being of women and their children. Evidence consistently demonstrates that IPV is associated with increased risk of mental health disorders, including depression, post-traumatic stress disorder, substance use, and suicidal ideation. It is also linked to adverse reproductive and physical health outcomes, such as unintended pregnancy, miscarriage, sexually transmitted infections, and low infant birth rate. Beyond individual effects, IPV has intergenerational impacts. Children who are exposed to violence are more likely to experience behavioral problems, reduced developmental outcomes, and an increased likelihood of experiencing or perpetrating violence later in life. This is partly due to the co-occurrence of IPV and child maltreatment within households, as well as the lasting effects of witnessing violence during critical developmental periods. Furthermore, importantly, while emerging technologies, including digital interventions and artificial intelligence, offer promising opportunities to enhance identification and intervention, they also introduce new risks. Advancements in communication technologies have enabled novel forms of abuse, such as uses of location tracking, digital surveillance, and recording and dissemination of violence. Current responses from governments and technology companies have not kept up pace with these developments, highlighting a critical gap in prevention and regulation efforts. As such, technology must be approached both as a tool for intervention and a potential mechanism of harm. Now I'm going to talk about our recommendations for health educators, public health practitioners, and clinicians. So health educators, public health practitioners, and clinicians play a critical role in strengthening the effectiveness and reach of intimate partner violence interventions. Our first recommendation is to prioritize the utilization of best practices and programs that are appropriately tailored to the needs of the individual. This requires a sustained commitment to the continuous professional development, and including staying informed on emerging evidence, best practices, and demonstrated patterns of success across IPV interventions. Such efforts will enable professionals to thoughtfully implement and adapt programs in ways that enhance accessibility, relevance, and overall impact. For health educators in particular, it is essential to recognize that limited access to resources and broader systemic inequities, such as economic instability, housing insecurity, and barriers within healthcare and legal systems, play a significant role in the shaping of IPV risks and outcomes. As such, health educators must engage in advocacy not only at the individual and community levels, but also at the political, economic, and structural levels to promote sustainable, meaningful change. Addressing these upstream determinants is critical to reducing disparities and improving long-term intervention effectiveness. Additionally, public health practitioners and clinicians are central to the early identification and referral of individuals experiencing IPV. Strengthening their capacity to recognize signs of IPV through comprehensive training and ongoing training is essential for timely intervention and appropriate care. Accurate identification facilitates access to supportive services that may prevent further harm. Furthermore, the evidence emphasizes the importance of establishing robust referral networks and ensuring continuity of care. One-time interventions or isolated training efforts are insufficient. Instead, integrated systems that include follow-up resources, sustained support, and interdisciplinary collaboration are necessary to promote long-term safety and recovery for survivors. Overall, addressing IPV requires a coordinated, multi-sectoral approach grounded in cultural competence, evidence-based practice, and sustained engagement. By aligning educational efforts, clinical practice, and public health systems, and by advocating for structural change, professionals can more effectively contribute to the prevention of IPV and the support of the affected individuals.
All I really enjoyed reading about this topic. Specifically, I enjoyed reading the articles that targeted survivor empowerment and self esteem. I thought they did a great job of encouraging survivors to believe that they can get out. There were many articles that also targeted the social and political aspects that affect IPV, and I thought that these showed that IPV can stem from larger systematic issues rather than just having to do with the survivor or the perpetrator. By targeting these systematic issues, we may be able to make changes within institutions which will create longer term help. I thought that these interventions that targeted the perpetrators were fascinating to read. I think that by seeing why the perpetrator acted the way that they did, we might be able to create overall change for people who might be at risk for possibly perpetrating. My favorite interventions that I read had to do with resources such as housing and economic empowerment. I thought that these were great in actually making change. Even if somebody knows how to get out of a situation, they might not be able to due to not having the resources. And lastly, something that I noticed throughout the articles was the change between different articles between the word survivor and the word victim. I think that survivor is a better word to use since it is more empowering. It makes it seem less like the person is at fault.
One of the things that really stood out to me throughout this project was the dual role that technology plays in the context of intimate partner violence. On one hand, there's so much potential for tools like AI and digital platforms to improve screening and early intervention, but at the same time, it became clear that these same technologies can be misused by perpetrators in ways that actually exacerbate harm. That tension really highlights the need to be thoughtful and intentional about how technology is developed and implemented in this space. Another key takeaway for me was how essential cross disciplinary collaboration is. IPV is not something that can be effectively addressed by one field alone. It requires coordination across public health, healthcare, social services, and policy. Seeing how these sectors intersect really reinforced the idea that a more integrated approach is necessary to create meaningful and long lasting change. I was also struck by how impactful peer support and social cohesion were in many of the programs that we reviewed. There's something really powerful about shared experiences and connection, and it seems to play a significant role in improving outcomes for individuals experiencing IPV. It's not just about providing services, but also about fostering a sense of community and support. And finally, I found it particularly interesting that many of the most effective programs didn't focus on IPV in isolation. Instead, they addressed it alongside other health and social challenges. That more holistic health approach makes a lot of sense, especially when considering how interconnected these issues are, and it seems to lead to more sustainable improvements and overall well being.
IPV is extremely widespread in terms of how it can occur, who can be affected, and who can be the perpetrators. Overall, it is our job to create tools that will be effective in minimizing the amount of IPV that is prevalent today. Going forward, we are excited to see what interventions will be created and how they will target specific groups. Thank you for watching. We hope you enjoyed everything we had to say. Here are all the references we used when creating this presentation as well as doing the literature matrix.